Welcome back to Family Planning and Abortion for Medical Students. Today, we will finish our mini-series by summarizing what we have learned and practicing with a few cases. To remind ourselves, these are the major categories of contraception that we have covered over the past several videos, discussing the mechanism of action, risk, benefits, and effectiveness of these methods. Our main learning objectives today are to understand the themes and reasons to choose one category over another depending on varying patient factors, as well as to apply our knowledge in practice cases. These past few videos have included a lot of information, so please feel free to go back over these slides as you need and check out the resources in the folder to learn more about each method. I want to consolidate what we've talked about by pulling out some key themes. One theme is that methods with less maintenance and less room for human error lead to greater effectiveness. For example, many of these methods have regular use effectiveness versus actual use effectiveness. This is part of the reason why low-maintenance methods, such as LARCs, are more effective than daily use methods or methods that are required each time a patient has intercourse. Another theme is that almost none of these methods protect against STDs besides condoms, but this method alone is not as effective at preventing pregnancy, so these methods can and should be used in conjunction with a more effective method in patients that desire both effective pregnancy and STD prevention. One other really important thing to understand from this lecture is that regardless of effectiveness, ease of use, and side effects of any of the above methods, the most important consideration is the patient and what they are willing to use. A patient may be a great candidate for the combined oral contraceptive pill, but if they tell you that they cannot remember to take a pill every day, then that is not the best method for them. Similarly, although IUDs and implants are indicated for most patients and are extremely effective, some people are simply not comfortable with the idea of a device in their body and will not go through with placement. So trying to push a patient into one of these methods is pointless and can harm the patient-physician relationship. In short, the best method is one that a patient wants and will use. Lastly, if you're ever unsure if a medical condition, medication, or family history is compatible with a certain type of birth control, chances are it will be included in the Contraception app, so be sure to check that out before making recommendations to patients, especially in those patients with complicated medical histories. Okay, so I wanted to give you the opportunity to practice some of the things we learned with a case. You can pause now to read the case over and think about the question. Also feel free to review the prior videos and slides as you consider Ashley's options. So let's consider what we know about Ashley. She was previously on a non-hormonal, low-maintenance IUD that she tolerated well, a long-term relationship. Let's now consider the major categories of contraceptives. She could be put on a hormonal contraceptive, but not one containing estrogen due to her history of DVT. This would rule out combined oral contraceptives, the patch, and the vaginal ring, but she could use the mini pill as this does not contain estrogen. Because she wants to conceive in a few years, sterilization is ruled out as well. As for LARC methods, she could try the hormonal IUD or get another copper IUD since she tolerated this method well in the past. She could also try the implant. As for the birth control shot, this would not be a great option for her because she is specifically concerned about weight gain and because it can take months to years to return to normal fertility with this method, so there would be no point in her starting now if she desires to get pregnant in 1 to 2 years. As for lifestyle and barrier methods, Ashley has indicated that effective birth control is important to her, and these methods are significantly less effective than her previous method. In addition, although she is in a long-term relationship, she should still be counseled on STD protection. So there's no right answer here, but we've eliminated some options that would not work with Ashley's goals and her history. So now we can counsel based on what will work best for her out of her remaining options, as this is a shared decision between Ashley and you as the physician. Let's try another case. You can pause now to read it over and think about the question below and Jenny's options. So let's consider what we know about Jenny. She has had 3 children, most recently 1 week ago, and is breastfeeding, living with her husband and children, does not have regular access to transportation, and does not like the idea of using devices. If I were Jenny's physician, I would start by trying to understand the aversion to having things placed in her body first and answer any questions or concerns that she had. But if she still did not want any of these methods, then she should not consider the implant, IUD, or vaginal ring. Jenny is undecided about having children in the future, so sterilization is not an option at this time. Next, Jenny's postpartum and breastfeeding status is important. As we discussed in the hormonal methods video, estrogen-containing methods are contraindicated immediately postpartum due to higher risk of blood clots, so she would not be able to use the patch or combined oral contraceptives for 3 to 4 more weeks. So if she wanted to start birth control today, she would not be able to start either of these methods. She would be able to start the mini pill now, as this contains only progestin. Because Jenny is breastfeeding, she could also consider lactational amenorrhea. She would need to be extensively counseled that this method only works with exclusive breastfeeding, if menstruation has not restarted, and only until her infant was 6 months old. As for the birth control shot, while she has no contraindications, lack of transportation is something to consider here. If she is not able to make it into clinic every 12 weeks, this may not be her best option. Additionally, Jenny should be offered the use of barrier methods as primary contraception or combined with another method if she desires STD protection as well. Again, there's no right answer here, but we have narrowed down some options and we can now come to a share with Jenny. Thanks for listening. Please check out the resources for more information. Next, we'll be talking about reasons why some patients may not have access to some or all of the contraceptive methods that we've discussed.